This evening, you came to hear our guest speaker, Dr. Laura Curiel. I'll try to say that right. Okay. She's going to be speaking to us about making non-invasive treatment of prostate cancer a reality for everyone. Dr. Curiel is a scientist working with high-intensity focused ultrasound. Some of you have heard of HIFU. Okay, that's the short term. That's what she works on. And that is for minimally invasive treatment. HIFU has the potential for selectively destroy or interact with cells located in a targeted zone. She holds a PhD in imaging systems from the National Institute of Applied Science in Lyon, France, and a master's degree from the University of Lyon. It's during her graduate research work that she started working in HIFU and had the opportunity to work in a pioneering group that developed the Albathen, something like that. She'll say it right, and with a better accent than I have. A clinically available device for the treatment of localized prostate cancer. She participated in the development of the second generation of the device and the development of treatment parameters for treating patients with radiotherapy failure with HIFU. Her current research activities comprise 3 different directions: new therapeutic application, better guidance, and better monitoring for HIFU. Dr. Curiel is an adjunct professor in the Department of Electrical Engineering at Lakehead University and keeps active collaborations with different clinicians interested in this minimally invasive technology. We welcome Dr. Curiel.
Thanks. So first, I'm going to make almost a disclosure. So I'm a PhD. So I don't know how to define that. One time, a friend of mine defined it very well. So I am a doctor, but not the kind that makes money. So I'm a scientist, which means basically I am an engineer by trade, and then I continued my graduate studies into science. And I went into this technology that is HIFU, high intensity focused ultrasound. And I wanted to share you before I go into the science why I chose this field. So I am an engineer. I wanted to do something with my engineering degree, but more into the biomedical sciences or medical, something applied to medicine. And the main reason that pushed me there is that I lost my grandfather. At the time I was taking decisions for what I was going to be doing with my degree, and I lost him to prostate cancer. So I wanted really to go out there, and I didn't really choose what exactly. I didn't choose to go to HIFU. I went out there to see which laboratories were working with prostate cancer, and then I joined this particular lab where I made my graduate studies in France because they were working in this, and that's what took me there. So that made a very, very important journey for me that lasted almost 8 years working in prostate cancer and non-invasive treatment. And then I reconverted it myself a little bit. I will explain a little bit why. But basically, I started all this in prostate cancer, so I'm really excited to be here with you and share a little bit of what I did. So my point is non-invasive treatments. And I wanted to start with this funny picture. Is the future here already? So here on your left, you have a picture, and I don't know if you have followed all the Star Trek movies, but there's so many of them. But that is how they were doing brain surgery in the Star Trek. I don't know exactly which one. I don't follow them very much. And they were treating a brain tumor. And on the right, we have an actual device. We have an actual device that is being used today to treat not brain tumors, but to treat essential tremor. So they are ablating parts of the brain to regain some functions. So the future is here. What I meant is whatever we dreamt of in these Star Trek movies, some of it is actually happening already, and that's where we want to go. That's what we would like to do. Not being able to do surgery without having to do incisions. So what do we mean by non-invasive today? Because they're going to tell you a lot of things about we do non-invasive treatments. There is a lot of definitions for non-invasive treatments. There is endoscopy, there is percutaneous surgery, so where there's going to be a very minimal incision and then they're going to operate through. There's laparoscopic surgery, cryosurgery, gamma cameras, robotic surgery. So there's a lot of methods out there to do non-invasive procedures. So they actually look like that, although this is a funny cartoon that I found when I just Googled what is non-invasive surgery. So it's really very, very tiny incisions to get to the targets. However, HIFU has the capacity to do that even without any of those, even the smallest incisions. So that is probably the most well-known device, and is the one in which I worked with. It's called the Ablatherm. It's this EDA Technomed device to treat prostate cancer. That is actually their brochure picture. I kept year after year telling them it was not very marketable, but anyway, that's the marketing picture. I really think. I don't know what you think. I never really liked that picture. Anyway, it's not a completely non-invasive treatment because the treatment is made. The treatment is made actually through the rectum. So it's a transrectal procedure. That means that we are going to put the device that's going to make the treatment through the rectum, and then they're going to ablate the prostate. So for me, that's not really completely invasive, but it's minimally invasive because there's no real surgery, so the recovery time is really low. So what is exactly this HIFU? And I want to talk to you about the science behind this high-intensity focused ultrasound. And that picture really shows us what are we doing into the tissues. So that's how it looks like when we use some of these high-intensity focused ultrasound waves, and we send them from the water to the water surface. So the first picture is we don't shoot very high, and then we keep increasing the power more, and then we get to this point in which we can actually make the water boil. So we go to very, very high energies, and that's why we are going to destroy the tissues. That is, for instance, an acoustic fountain. We're doing, again, HIFU and sending it at the highest power that we can. And we can completely boil the water and shoot it at distances that are very, very high, probably around 30 centimeters. So it's very, very high temperatures. And here's the kind of lesions. Now, I like this picture because this is a transparent phantom of tissues. So that's how tissues would look like if they were completely transparent. So those are the lesions that the HIFU causes into the tissue. This kind of tadpole-shaped, cooked tissue-like lesions inside. So that's how they look like. So what happens is that we send this sound wave into the tissues, and the sound wave, the ultrasound, it behaves exactly like sound. It goes inside it propagates inside our tissues, but it's going to cause at the focus that the temperature is going to go high. So it's very, very high. It's about 80 degrees in just seconds, and it's going to coagulate the tissues. So it's very focused, which means that all the energy that we're going to have before or after this focus is not going to cause any damage to the tissues. It's very much alike if you ever played with a lens and you were trying to cause some fire or burn something. It's exactly the same thing. If you go and put your hand close to the lens, nothing happens. But if you happen to put it at the focus, then you get burned. So it's exactly the same, except that instead of being light, we are using sound. And the lesions are tiny. This is about the size of a rice grain. And then we just put them all together and get a big, big lesion. The advantage of using this HIFU is that it's going to be precise then. We have the small rice grain sized lesions. We're not going to be needing any incision. We don't, of course, use any radiation. So that means a little bit less discomfort for the patients, faster recovery times, and then we can repeat the treatment, and we can combine it with other therapies. So from the physics point of view, we're going to send this ultrasound. The molecules are going to vibrate at the focus. All that energy has to go somewhere. It gets absorbed. The temperature goes up, and we can coagulate the tissues. And these are the clinical devices that exist out there. So probably the two more well-known are Sonablate and Ablatherm, and those two are for treating BPH and prostate cancer. So they are the ones that have had the most patients treated, the most cases out, and it's probably the most popular application of HIFU out there. But there's other devices like the Exablade and now the Sonalib that are used for more general purpose applications. And we have actually one Sonalib here in Thunder Bay, and we use it to treat uterine fibroids, which are benign tumors of the uterus. It's the same principle, except that the Sonablate and the Ablatherm use ultrasound to guide the treatment, and the Exablade and the Sonalib need an MRI to guide us. Then there is this device known as HIFU that was made by the Chinese. It's used in some places, but not very much, and it's supposed to be multi-organ, so it's really for treating everything. But they have debatable results with that machine. And a very novel new one that was developed in Toronto, made by a company that's not Profound Medical. It's just in clinical trials, and it's also to treat prostate cancer. Now, the difference with this new device is that it's going to need also an MRI for guidance, and the treatment is made transuretrally. So it's not transrectal like Sonablate or Ablatherm. This is going through the urethra. So it has some advantages and it has disadvantages, but so that's what it's out there. That's right, I didn't move. So the fact is, even if HIFU sounds like something new, it's really not that new. The first applications of HIFU are from the 40s. The first developments were made in science by the Fry brothers, and this is how their device looked like. And they were proposing it to treat brain tumors. Actually, HIFU was earlier than ultrasound imaging. So HIFU was the first ultrasound application in medicine that existed, even though everybody thinks that it's ultrasound imaging. But the challenge with HIFU in the 40s was that we could not guide what we were doing. So it was very hard. We had a very nice tool that was almost like a big gun, but we were actually blind, so nobody there shooting, which was a good thing. And what changed is that with ultrasound imaging and then with magnetic resonance imaging, we were able to see where the tissues were, target, and then the treatments really started. And then HIFU, which was the first application for HIFU, was then prostate cancer. The first developers were in France. It's the machine that I showed you, it's Ablatherm. It's the ones that have the largest number of patients that have been treated, and it's probably the most widely sold machine in the world. So those are in blue, they are the countries where they have sold one of those machines, and in gray where it is not sold, probably because it's not approved. So we do have those machines in Canada, and well, I also know the machine in Mexico, and a lot of Americans that get treated in both, depending how far they are from the north or the south, they go to those countries. So it's pretty well known and used for prostate cancer now. However, and this is what I wanted to touch with you, there is indeed a debate behind HIFU, particularly for prostate cancer, and that is something that we have to face as scientists, also the patients that make this decision and the physicians that help them make it. So it has a lot of advantages. It's not surgery, there's fast recovery, and then it can be used after radiation failure, which gives more options to the patients. But all the physicians know it, and it's a reality. It's not for everyone. It has to be for a localized disease. So once it's out of the prostate capsule, it's not really a good option. It has to be for moderate Gleason scores, so it's basically for low risk or intermediate risk cancers. Because after that, the results are really not that good. The cost, right now it's not reimbursed, and it's probably just a circle. It's not reimbursed because they don't think it's good enough, and since it's not good enough, then it's not reimbursed. It's going to keep being costly. And then there is a lot of physicians still that hesitate to send patients to these treatments because they think it's going to stop the alternative for treatment for the patients. That has been changing lately because a lot of the groups that have actively used HIFU for prostate cancer have published the ways to treat patients after failure of HIFU. HIFU can be repeated. There can be radiotherapy after HIFU, even surgery after HIFU. So physicians have been publishing what to do if HIFU fails, and that's changing little by little. But in countries where it's not well known, there is still a little bit of hesitation from the physicians to say, yes, this is a good option for you, because there's not a lot of information out there to treat patients after they fail this. So what are the reasons then behind this debate? A lot of it is that there are real scientific reasons or clinical reasons, but a lot of them, unfortunately, is what we call in science the problem of the acceptance model. There is a lot of the user, when they are going to accept new technology, has to perceive this new technology as something that is useful and something that is going to enhance the job. And it has to be perceived easy of use. And unfortunately, that does not mean the user is not you. Unfortunately, the user is your physician. So if it's not useful, if it does not enhance the job of the physician, then it's unlikely to be accepted. And that is part of the problem that we have with HIFU. So I think a lot of this has changed if beneficiaries are starting to push and to look for, they find willing physicians, those that want to accept this new technology, and that's how it has been accepted more and more. Unfortunately, we cannot just say, well, then the patient should be pushing to get this technology forward, because in medicine it's a necessity. We need really the physician to guide on the decisions. It's a very difficult situation. It's a very difficult debate. I would say that a lot of things have changed in medicine when the patients have pushed the doctors to make some decisions. But it's also a lot of their responsibility how they treat the patient. So it's really a difficult situation in which we are. And HIFU has suffered from this. Mainly because it's seen as if it should solve everything. It should be just a surgery without incision that should be giving the same things that the surgeon is giving. And it's actually, I believe, that we should stop looking at HIFU and a lot of these options as something that has to give a solution. I think we should start looking at HIFU as a tool, one more tool to treat some kind of diseases, some kind of patients, and not everything. So it's not a solution for everything. It's just one more tool that has to be there for the right person. It's all about personalized medicine. HIFU is competing with very well accepted solutions that have had lots of years behind them and thousands of patients that have been treated. So it's competing with radiotherapy, which is an adequate solution, and it's perceived as the adequate solution, non-invasive adequate solution by a lot of physicians. So it's competing with radiotherapy, and it's at this point it's a very difficult comparison because we're talking about thousands of patients that have been treated with both. And we have also watchful waiting as an accepted strategy. So it's still accepted, it's still used by the physicians, and it's still probably good for some patients. But this strategy is where a lot of the low risk and intermediate risk patients end up. And those are the patients that are the good candidates for HIFU. And actually some of the things that broke this resistance in Europe, and specifically for the Ablatherm, was exactly this. A lot of these doctors that were treating with watchful waiting patients, they decided, well, the main reason why I have a lot of these patients waiting is because I don't really know, it's not really well advanced. The disease is not well advanced, and I also have a patient that has higher risk than others to have a surgery. So I really prefer to wait and see what happens. And when HIFU came and they showed them, well, in this case, you're going to have a tool that is going to allow you to do something, and you are not going to have a surgery. It is only done under local anesthesia, Raki anesthesia, so then you are going to have an option to treat those patients. And it's mainly those patients that get treated in Europe right now. So is HIFU going to become the future treatment? I don't think so. I think it will be just one more tool in the treatment of cancer that is going to be indicated for some patients, not for all patients, but it's going to be one more tool. Just as radiotherapy, just as patients can go through chemo and radiotherapy and surgery depending on the journey, HIFU can be just one more step, a different step that is indicated at some point and not for other patients. It's just going to be like it is with drugs. We try one drug, and if that one doesn't work, then we try a different one. HIFU is going to be one more of those tools. So now what about HIFU? Where is HIFU going? Do we still need to improve it, or we just need to push it and make it be used by more physicians? I think there's still a lot of room for improvement in HIFU. HIFU has to be made less invasive. It has to be better guided, and we have to have earlier detection. So of course that's going to benefit everybody. And actually that future is already here. The same company that made the Ablatherm has done now a machine that they call Focal One. It's the same technology behind, but it's designed to do treatment of only the tumor. And that hasn't been done for a while because it's very difficult to see tumors. And I heard what they said about not being able to see the tumor in the MRI. It's very, very difficult to see a prostate cancer tumor in the MRI. Sometimes they don't see anything. They do prostatectomies, they get them out, and the pathologist said, I don't know how you couldn't see it, it's pretty big. So that is something that is we do not have the technology in imaging to be absolutely sure that we are looking at the tumors in the prostate just yet. Now, some developments are out there, and that's why they create this machine. So they can now get some of the MR images, fuse them with the ultrasound, and treat only the prostate tumor and not the whole prostate that they're doing now. So which means that for the patients that are candidates for this kind of treatment, they are going to have less side effects even than with the normal HIFU. Likely going to have just part of the prostate treated, very good chances of keeping sexual functions, and then, well, even the normal machine incontinence is very low in this machine, but that's even improved with this machine. So there is a lot of improvement for this technology, and currently it's being used. Everything is being done then for prostate cancer using ultrasound for guidance. We can go for guidance with MRI, and some machines are already doing it, and that's how this kind of guidance looks like, although this is actually for uterine fibroids. But clinically, we can do more. So what are we doing here in Thunderbird, in the institute where I work at TBRI? We work in two parts, basically. There's some work that is done in clinical, that is translation or clinical validation of the devices. But most of my work, I am a scientist, as I told you, so I am almost always, unfortunately, excited about the next thing and leaving the things that we've already done to be translated by other people. So I work a lot in novel guidance for the treatment. So I had this neat idea when we were having so much trouble looking at these prostate cancer tumors in the MRI, because I was talking with a lot of biologists that are friends of mine. And I was thinking, what if we had a way of looking at those tumors, but not just because they look different in the image, but we had some kind of marker, biological marker, that will tell us the tumor is there. Now, the two big advantages of that would be, one, they would be easier to see, but the most important is we would see what is wrong, what is not working. So we would have markers that are telling us for very small cancers that we have them and what kind of cancer we have. So we could treat it better with HIFU, but not only that, we could likely have the right drug to go against that cancer, because not all cancers are made equal, you know that. So there's more aggressive cancers and less aggressive cancers. And I saw that when I was working with this machine. So how do we treat the patients that are at higher risk? Probably biology is going to give us the response. So if we had a way of marrying biology with the imaging,
and then get pictures of the aggressive cancers, then we probably can make better decisions. Like we have to go with everything we have right now. It's not just HIFU, it's also going to be radio and chemo, or we can just do HIFU, or maybe we should combine this and this. The more information we have, the better. So we're trying to work in that, in novel guidance using biological markers. So these biomarkers are going to give us more about how the tumor is working, and how can we combat it, and then that's called molecular imaging. And in my lab, I work doing then antibodies that are for prostate cancer. So we have these antibodies that are attached to the prostate cancer cells, and then I associated those antibodies with nanoparticles that are magnetic. And then I can see those nanoparticles in the MRI. So for now, we're really working at the cells. I do these experiments with prostate cancer cells, and we're able to see those prostate cancer cells in the MRI and also in animals. Now, the advantage of this is that this antibody that I chose, it's called a PSMA antibody. It has another effect too, is it's internalized by these cells and then kills the cells. So it's what we call being in the area of the therapeutic. So we have a therapy that is also part of diagnostic. So these are two pictures. This is brain. It was a different application, but it's the same kind of nanoparticle going against a glioblastoma. And then on the left, we see the normal MRI. And then on the right, we see the tumor that is actually shown by the appearance of these magnetic fields. And the tumor can be very well delineated. And we're using that for prostate cancer. This is a mouse, though, but we have the tumor before we inject these nanoparticles, and then after we inject them. And we clearly see how they become a different color, so they become more magnetic, and then we can depict the tumor very well. So the idea is to use these new images to then guide HIFU. Now, in clinical, what we do also at the Institute is validating machines that are out there already, and this is the Sonalib machine from Philips that we have been validating for uterine fibroids use. But that's uterine fibroids. So what about future prostate, for future targets, and what about the prostate? I mean, that's where I started my journey, and I long to go back to that. But it's a completely different technology, and the machine that we have right now at the Institute is not made for prostate. I would like to do it, and I think the future is almost there, and that's where I'm trying to push to get some work together with industrial partners. Not long ago, it was announced that this machine that was developed in Toronto by Profound Medical are getting associated with Philips, which is the MRI that we have here for doing the treatment with HIFU. So if they really get associated and start working together, then we have a chance to have here that HIFU prostate cancer device and maybe candidates to do some clinical trials with our device. So that's what I really dream that will happen, so I can go back to prostate and out of the lab and more into the clinic. But I'm also looking more into the future. That is going to be the clinical part, but I really think that HIFU, besides this molecular imaging, has even a further future into something that is more, that is even more married with biology. I think we have to go out of ablation, and we have to start doing localized drug delivery. Now, prostate cancer is not very widely treated with chemotherapy, but the few of you that have had chemotherapy know that the side effects are really not the best thing to have, right? So what if we could have a better chemotherapy with lower doses? So those side effects should go away. And the way of doing should be to be able to just deliver the drug into the tumor and leave the rest away without having to send so much drug. Now, that is possible with HIFU, and it's also possible to potentiate other therapies with HIFU. There is a lot of evidence out there that if we treat with HIFU before radiotherapy, the response is better. So it hasn't been done in large clinical trials, but we do know that it's happening. So this potentiation of combining HIFU and then following it up by radiotherapy is also a possibility, and is some of the other things that we are trying to explore in clinics right now. So we would get both things. So this delivery, how does it happen with HIFU? Well, I told you that it's about vibrating molecules. Well, what about instead of going with everything and the highest energy that we have, we lower that energy. What's happening is that the cell membranes are actually opening up and then they close back. So when they are open, we can deliver the molecules that are going to treat the cells and then they are going to respond to the drug. So we are just locally having an effect and not everywhere. So that's what we call molecular delivery or localized treatment. And we have been doing some experiments in the lab. We have been treating some cancer cells, and they respond well to the treatments. We have loss in cell viability after we deliver the antibodies that are designed to kill the cells. We also have some new devices. That's the same thing. The cells just as soon as we send the ultrasound, we get a better response than without ultrasound. And we're actually making new devices to explore more and more these in cells. Once it works in cells, then we go to animals, and then we can translate it into humans. And I think that's what I have. So now I'm ready for all your questions. Or comments.
I think it's amazing to have someone who is excited about doing what they're doing, like you are, that doesn't say, this is going to take care of everything and fix everything. And to say that it's just a part. That was really unique. But what questions do you have? There's a lot of information. Yes.
You had a map up on the screen.
Yep.
And it looked to me, I may be mistaken, but it looked to me as if this HIFU is not in use in the United States.
No.
Can you explain why?
The FDA has not approved HIFU.
Why?
The main reason is I was there when they were trying to get their approval. Now apparently they are finally going to start the process to get approved. The FDA wanted what we call a randomized clinical trial, in which they would treat patients with HIFU and without HIFU, with an alternative to HIFU, and then see which one was responding best, if there was an advantage or not to either of them. And unfortunately, one of the things that they wanted to do with the HIFU at the beginning was to offer the treatment and immediately make a prostatectomy to the patients to see how safe it would be. And that was not accepted by the regulations in Europe. In Europe, you cannot have any clinical trial that is not going to directly benefit the patient. So if you are still going to have a surgery in the patient, really that is the treatment. You cannot submit them to a treatment before that is not going to benefit them at all. So there was a clash of two worlds in there. That didn't happen in Canada. That's why it's approved here, neither in Mexico or the rest of Europe.
It just seems odd to me that a country with such an advanced medical system as the United States has is not on board.
Yeah.
It's strange.
That was the reason. Now, they have, after all these years, they finally gave up in the safety part, and they are finally going to start the randomized trial. Now, that randomized trial is really needed, because that's one of the hesitations of Canada to reimburse HIFU right now, that the results of HIFU are the same as surgery, not better. So they are saying, why would I pay for this procedure if surgery is doing as well as the procedure is? So likely the result is going to be the same, but then I would say, why would I have to go for a surgery if it's going to give me the same? So that's going to be where the push from the patients might make things change.
Is there a matter of economic or political turf happening here? A lot of money is spent on conventional surgical treatments. Anything new tends to displace the old, and those who have an interest in the old may want to resist.
Yeah, there is a lot
that
of
happening?
There is a lot of that for HIFU, unfortunately. Now, it's not the surgeons that are fighting, it's the radiotherapists that are fighting, so the radiation oncologists that are fighting. It's very well accepted, radiotherapy, it works, and HIFU as a new technology has to fight against them. And it happens for HIFU in a lot of areas, unfortunately. Now, I don't know how that's going to change. Again, I would keep pushing, saying it's not one or the other. You have to have different tools, and then you choose the one that's best for your patient, not the one that you know how to do. So, unfortunately, that means a radiation oncologist versus a surgeon or an interventional radiologist, who is the person that does. There's a lot of turf in here. Unfortunately, that's what we have seen now.
What does the treatment cost?
In Toronto, the last number they told me was $25,000 to $30,000 for a treatment, and if you have to go for a second time, it was $5,000. It's about the same price in the United States for uterine fibroids. It's always around $30,000. In Europe, it's reimbursed, so it's free. In Germany, they have a mixed system. It was costing them 15,000 euros, and now it's reimbursed by the insurance companies because they realized it was cheaper than sending people to surgery. I think a lot of problem with HIFU is that nobody has factored in the cost of people not going back to work, or of people having to stay in extended home care after a surgery. Nobody really counts that. I don't know why. Probably because it's patients who have to pay for that part, right? Yes.
5 years ago, right after I got home from surgery, my chum called me. He's living in Calgary now. He used to live here. And he told me he had his prostate treated by robotics type. That would burn cells, or?
It could be that there's also robotic surgery for prostate.
Sorry?
There is for prostate. There is robotic surgery, which
Yeah.
is basically it's a robot who's doing the surgery, but the surgeon is operating the surgery.
Okay, yeah.
But it could also have been HIFU. It's either there's both of them. It's just two different things. It's basically the robotic surgery. It's a surgery, but more precise because the machine allows you to get more
Well, I'm
precise.
sure he said surgery, but at that time he's saying much better over there, and I'm not in a mood of listening very well because I just had the surgery here. But he says actually the doctor could almost do the operation if the doctor was home because it's all
Yeah.
done by TV. Like.
Well, the HIFU has that possibility too, but they don't do it. It's usually the urologist who's looking at where they are, and they are pressing the button, and they chose what they burn.
Now, what kind of indicator would you get if you had HIFU therapy, whether it was positive or negative success?
They use PSA first.
Pardon me?
PSA. So immediately after the treatment, as suspected, the PSA goes really, really high because we just completely ablated the prostate. So they wait a little bit. They wait about 1 week, and then the PSA has to go back to like base levels, normal levels, and that's an indicator that everything went fine. If it doesn't go back, then they perform biopsies to confirm that it's really gone or not.
Yeah, I have an acquaintance, and he was in some kind of trial in London, Ontario, I believe it was, and his was negative, the results. And so anyway, so he suggested there that he go to Princess Margaret for some other type of therapy. What kind of therapy would be available? Radiation?
Radiation, yeah. Usually after HIFU fails, we can do radiation. There's also a possibility to do hormonal therapy that also works. And some surgeons do operate after, but the surgeon has to know what this looks like. But radiotherapy after HIFU works. The opposite also works, though. If you are in failure of radiotherapy failure, HIFU can be tried.
Any more questions? Yes.
We had a presentation on HIFU once before, but something quite different. You touched on a bit. Is this using a little bit lower intensity that reaches the cell membrane, allowing the uptake of a chemo of a sort? Now, is the chemical used, or whatever, specifically designed to work with HIFU, and is it administered systemically? That is, you take it through the whole body, but then because of the cell membrane being breached, it gets to those cells.
So there's two things that are done with molecular delivery. There's one where we mechanically open the cell, and then the cell goes in, and then yes, it's systemic, the drug is systemic. And HIFU gives another option for molecular delivery that is pretty elegant. We encapsulate the drugs in thermally sensitive molecules. So then we heat up with HIFU, and the drug gets released only where we heat it up.
So it travels in the body.
Travels in the body, but it's
But it
completely
can't do it,
inert,
it's
so
encapsulated.
it's encapsulated, so it's not toxic. And when the place where we heat up, that's where it breaks, and that's where we deliver.
And this was developed, I noticed Ingeborg Zeebe's name, she works here.
Mhm.
So was this developed, any of it in Thunder Bay?
Yes, so the what that I'm trying with Ingeborg is it's for opening the membrane.
Oh, yes.
So that's the one. The one that's thermally, that's another drug company. They developed it long ago. They call it Thermodox. It's doxorubicin that is thermally. That one we haven't tried yet. With Ingeborg, we work in that one. And she designed it specifically to attack proteins in the cancer inside the cell that are the ones that are transforming the cell into cancer cells. So yeah. That's why I really think that the future of all this is really going to be marrying these with biology, because it's the other half. We can do so much more by combining drugs and this kind of thing.
It's so amazing that work's being done in Thunder Bay.
What?
Everybody thinks of things coming from somewhere else. This will go to the world.
Yeah.
The positive results will go to the world.
A lot of this work, when I came because it was interesting and they wanted to do HIFU and they attracted me. But a lot of it is also, we have this nice, very, very nice mechanism with the foundation and the hospital. And they give this, it's a very interesting model that does not exist in a lot of places, what they call the seed funds from the Discovery Fund. So we have these crazy ideas at some point, the scientists. And unless we go out there and we have money to test them, we cannot really prove them. It's expensive, not extremely expensive, but it costs money. So the Discovery Fund give us these very little seed funds to test our crazy ideas. And if they give something, then we go to other larger agencies and we show them, look what we tried and we did with these $10,000. So now give us serious money so we can keep working. So that's actually something very good about the foundation and how they work with the science.
Can you look in your magic ball and see when this will become reality? In years?
The biology, the biology part. The thermal part is already becoming a reality. The antibodies, we are now, I would say it's about 5 to 10 years to really test it, start testing it in humans. We're trying to shorten that by using other drugs that other people have already gone through the clinical trials, so we can reduce that. And if we do that, then we can think about 5 years. But that's why we never really stay just in the preclinical and in the lab. So we keep doing other stuff that is more translatable, like testing, so we can reach all the spectrum.
One of the things that you mentioned, I was trying to follow it, was about something that you were, I think this might be there, that nanoparticles were used for diagnosis but it also destroyed the cells. So it was a treatment as well. Why isn't it just used as a treatment?
Oh, it is used as a treatment only. This particular antibody was proposed as a treatment. Now, it wasn't given very good results only. The body becomes resistant to it at some point. It's a little bit what happens with breast cancer and HER2. If they become resistant to this antibody, and then there's no more response. Now, whatever we can get, if we can see what it is, then if it gives some response as well, that's good. But if we know for exactly the tumor is, then we can also excise it and find two other options. That again, we have to just combine. But it was used. It's called J591 antibody. It goes against prostate-specific membrane antigen, which is a part of the prostate cancer. It's on the cell membrane of the prostate cancer. Now, unfortunately, it became resistant, one thing, and second, it was mainly expressed by low-risk prostate cancer. So again, that's not the one that we really want to go after. Those are responding pretty much well, so we want the biology to go for the aggressive ones.
Side effects. Side effects compared to surgery.
So the side effects of HIFU compared to surgery. Incontinence, it's lower. Sexual function, it depends how the treatment was made. It could be as bad as surgery, but if there's they have some nerve sparing techniques that can do it less, but it's not for everyone. Again, it depends on where the tumors are, if they are bilateral or not. It's basically the same, except that there's very rare neck stricture and almost never any fistulas, any problems like that. The recovery times is what is really very, very impressive. You go out the same day that going into the treatment. It's a day surgery. So I guess those side effects are gone.
On behalf of PCC and Thunder Bay, we'd like to present to Curiel. Thank you very much for a good presentation. I gather you must speak French too. Merci beaucoup de belle présentation.